Sorry.
No, that's great. We only have 20 minutes, so we should start on time. This is like no, that's fine, but thanks for being here. This is an intimate gathering. I think we kind of know each other, most of us, but I'm Doug White, and this is Kim Stanford. So we'll be kind of leading this discussion where basically what we're going to be talking about is how to kind of adapt an HIV screening program, leverage that program to expand towards syphilis screening and syphilis testing, and how you can use that maybe for expanding HIV prevention services as well. And I'll do the kind of the first half of the talk, giving some background, and then turn it over to Kim, who's really going to show the real world application of how impactful these syphilis screening programs can be. Let's see. We'll get this going. Where's my arrow key? There we go. Okay. So my disclosures, I do receive focused funding from Gilead that supports our HIV screening program. And Kim is a hardcore researcher and funded by like the NIH and all sorts of things. So basically, this group probably knows that the emergency department is just a critical venue for providing HIV screening, right? And for a variety of reasons. Number one is we are basically a major portal of care, right? EDs provide over 140 million visits to U.S. EDs each year. And it's estimated that 1 out of 5 adults have been to the emergency department in the preceding 12 months. We're also, for many patients, the only portal, right? Many of our patients don't access healthcare services anywhere else, and let alone receive like preventative services or screening for diseases like HIV. We also provide care to patients who are disproportionately infected with infectious diseases like HIV. This obviously creates this unique opportunity for addressing these epidemics. And for the same reasons that EDs are ideal for HIV screening, make them also ideal for syphilis screening, because syphilis and HIV share commonalities in terms of modes of transmission, the demographics, the social and economic conditions that lead to higher rates of these infections. So, but before we get into like how to expand your syphilis program and how to do more syphilis testing, I'll just want to get everyone up to speed with like the scale of the problem of syphilis right now. It's kind of mind-boggling. So the CDC, these are recent estimates from 2022. There's now well over 207,000 cases of syphilis reported in 2022. This is an 80% increase just since 2018. This continues a decades-long, just steady upward trend in rates of syphilis. There are, we haven't seen numbers of syphilis like this since 1950. And it's kind of remarkable that syphilis was almost eradicated. In the 1990s, syphilis was basically almost gone. It wasn't even taught in medical schools. In 1998 was like the lowest numbers of reported syphilis cases, and look at where we are just a handful of years later. It's also really important to just remind everyone that although we're seeing rates of syphilis grow across every demographic and in all regions in the U.S., there are significant disparities among racial and ethnic populations that are just disproportionately infected, and these mirror basically our health and social inequities. And then obviously congenital syphilis, we have to kind of mention the clinical importance here. There's over 3,500 babies born in 2022 with congenital syphilis, and 10% of those resulted in either stillbirth or infant death. And it's remarkable to think of just 10 years ago, there were only 300 cases of congenital syphilis in the US. And this figure here is showing that as we're seeing the increases in congenital syphilis just mirror perfectly the increases in syphilis amongst women of reproductive age. This is the syphilis testing continuum. So this is basically how emergency departments should think about strategies for expanding their syphilis testing. And this is basically stolen from how we think about HIV testing, right? From diagnostic testing all the way to kind of non-targeted or universal screening. And I'll just spend a couple minutes talking about these three kind of strategies, because they'll kind of set the stage for how we're thinking about rolling out different strategies for syphilis. So on the most simplest aspect is diagnostic testing. This is basically testing the individual patient because they have some sign or symptom that's consistent with syphilis, right? So take the patient with a painless genital ulceration. You're like, oh, this could be primary syphilis. Or they've got fever and rash and palmar rash. You're like, oh, secondary syphilis. So that is a diagnostic test, right? And we know that that is a high yield way to do testing, but it's going to miss many cases of syphilis, especially, the majority of syphilis, which is, clinically asymptomatic. Then as we move down this continuum of treatment, we move into targeted screening. Targeted screening is basically you're screening subpopulations of your ED patients, but there's some risk that those subpopulations have an increased risk for syphilis. So you think about any sort of cohort that's at increased risk. It can be people that are, basically trading sex for money or non-monetary items, or patients who report as men who have sex with men, or patients with active substance use or methamphetamine use subpopulation. So you're trying to target populations that are at increased risk. That's what targeted screening is. And then obviously what we're going to be arguing what we need to move towards is non-targeted screening, which is basically screening entire ED populations without paying attention to the individual risk. You're treating the entire population as the risk. So I'm going to give you just two examples of how we have rolled out targeted syphilis screening where I work, which is Highland Hospital, and then we'll move into Kim's examples of non-targeted syphilis screening. So this is a protocol that we rolled out now about a year ago where we no longer order individualized STI tests. So we don't order chlamydia tests a la carte or gonorrhea tests. We've essentially removed that option, and everything is now an STI order set. So this really facilitates comprehensive STI screening, including syphilis testing for any patient that the clinician is kind of working them up for a potential STI. We've taken it to the extreme, like if I want to order a chlamydia test or a gonorrhea test, it just won't let me. If I hit, send on my order set for chlamydia, the entire populated order set. So we're kind of forcing the clinician's hand just to co-test for everything. So this is a way to increase your syphilis screening amongst patients that you otherwise would be just working up for chlamydia or gonorrhea. The next targeted syphilis screening program that we've just very recently put into place, this is intended to increase screening for syphilis amongst women who you're evaluating for pregnancy. Right? That's our risk cohort that we're really trying to get that population screened. So I go and order any pregnancy test. It could be a serum beta HCG or a urine pregnancy test, point of care in the lab, and I process that order. This BPA populates, and it basically says, your patient's eligible for STI screening. So, it's up to the provider whether they want to, do comprehensive STI screening, which obviously includes syphilis testing. But this is a very low barrier, very easy way that we're just starting to roll out to increase syphilis testing amongst this population. We're seeing incredibly, high rates of syphilis, and also the congenital syphilis that will hopefully prevent by identifying syphilis. And then this is just showing our HIV and hepatitis C screening algorithm. This is our BPA for our non-targeted HIV Hep C program. So we're at this crossroads right now where I'm like, okay, I have this infrastructure that allows, non-targeted HIV and Hep C screening, and I'm like, okay, do I take it to this level where I now add syphilis testing to this algorithm? And that's where Kim's going to take over and pretty definitively show you, like, yeah, Doug, that's what you need to do, and this is why. Right? You're going to say that?
Yeah, I am.
Okay.
All right. Let's see. So basically, that was our thought, is syphilis, it's so much like HIV in so many ways, the same risk factors. It's asymptomatic for long periods of time. It's stigmatized, and for the same reasons why we have so much data showing that universal HIV screening is really the way to go, especially in high prevalence populations. We sort of took that and said, well, why would it be any different for syphilis? So actually 5 years ago now, almost exactly, we implemented universal syphilis screening in our ED. And this is what our alert looks like. And so this pops up for anybody who comes in who's under 65, who doesn't have a known diagnosis of HIV and who hasn't been tested in the last year. And this, essentially, we built it on the HIV screening infrastructure so that we could, for simplicity's sake, so that it would both of them would get ordered together. We've actually just last week now split them up so that even people living with HIV are now getting syphilis screened, because we found that even when we tried to filter them out, we were still getting about 10% of our syphilis positives in people living with HIV. So now they're separated, but for ease of implementation, we've put them together. It doesn't rely on a blood draw, so this gets ordered at triage, ideally by the nurses, or it gets ordered, it also will pop up when a clinician goes in to place orders. It doesn't matter, so even if they're placing like an ankle x-ray or whatever, it'll still pop up. Now they can decline it, but we do a fair number of these in people who are not getting other blood draws. And for what it's worth, about 20% of our positives come from people who are only getting HIV and syphilis as blood draws and not any other blood draws. So we do actually find quite a few in that population. And I will just add too, what Doug was saying about the STI order set. We actually have had an STI order set very similar to that was in place long before we started this, where when you go in to order gonorrhea and chlamydia, it comes automatically populated, pre-checked with HIV and syphilis. And even despite that, when we put this into place, we saw a huge bump in how many people that were getting tested for gonorrhea and chlamydia were also getting HIV and syphilis testing. So even with those other things in place, it actually made a big difference. Right, so a little bit of this I talked about already. Why do we like non-targeted screening? The big thing for me is that it really takes the stigma out of it. You're not saying, hey, you look like somebody who might have HIV or syphilis, to which everybody says, no, I'm not, I don't want to get tested. But if you just test everybody, they're much more likely to accept it. And it decreases bias. So maybe like I have some preconceived notion of, you look like someone who might, have risky behaviors or something, right? And so I might choose to offer you testing, but not you. It takes, gets rid of that because the computer's just saying, hey, everybody gets screened. And then it avoids a need. So, Doug talked about risk factors, right? Do you have sexual risk factors? Do you have drug use? Do you do other things? Well, how many of your patients are you asking those questions to? Are your nurses going to ask those questions? Are the patients going to answer honestly in front of a waiting room full of people? So, obviously I believe that is not a very efficient way to get to, identifying risk. And, frankly, a lot of people who you're going to find have positives, even if you had asked them all those questions, you probably wouldn't have gotten the answer of yes, you wouldn't have identified them as at risk. So of course the disadvantages are you're testing more people, so it may ultimately increase your costs of testing, and you may end up screening some people who really are low risk, and it creates some additional work because you're having to send additional tests and follow up on additional results. But just to share a little bit of what we have done in our program. So we looked back to see what things looked like for the 2 years before we implemented our universal screening and the 2 years after. And so you can see the number of ED visits was pretty comparable, but we screened a whole heck of a lot more people for syphilis afterwards. And you can see in those 2 years before, when people were screening, they were largely testing people with symptoms or people coming in for STI tests. We found 161 syphilis cases. And these are confirmed, not just like RPR positive. This is people we confirmed by clinical history truly had untreated syphilis. And in those same 2 years afterwards, now we're up to 624 diagnoses. So this is a huge bump. And that's 1.7% of our universally screened population. And just to quickly point out about this, this is from our original paper because the current data from the whole 2 year period is in the process of being published right now. But the percentages are the same. And what I really want to show about this is we looked at the ICD codes to see who was coming in, and we were pretty generous. Like, were they coming in with pelvic pain, with rashes, with discharge, anything that could be conceivably have something to do with STIs? And you can see it's under 10%. Of people that had ICD codes that were something that you could have otherwise identified as potentially like that they were at risk for an STI. And then in our more detailed analysis that is hopefully coming out soon, we looked at how many of the people with syphilis, so this is people diagnosed with syphilis, by the way. We looked at how many of them were tested for gonorrhea and chlamydia as sort of another surrogate marker of did they come in with something that would have caused an ED clinician to think they were at risk, and it was about a quarter of the people who were diagnosed with syphilis came in and had testing for gonorrhea and chlamydia. And the other thing I want to point out here is our percentage of syphilis cases that were among females. So in this initial analysis, this is from the first 7 months of our program, about a third of our syphilis cases were among women. And if you look, this is the CDC chart from the same time of the national numbers among women. It's only 17% of the syphilis cases nationally, which says to me that we are underscreening women by like a huge amount, which when you think back to this gigantic increase in congenital syphilis is a major problem. And to follow on that, we did not specifically target this screening to pregnancy in any way. This is a pop-up that shows up when they get triaged and when you put in any kind of orders. It has nothing to do with whether you're pregnant or not. But this is what happened among our pregnant population. With the universal screening prompt, you can see about the same number of pregnant women in the 2 years before and the 2 years after. But all of a sudden, we've gone from screening 6% of our pregnant women to screening half of them. So it's a huge bump. And you can see we went from 2 diagnoses of syphilis to 15 diagnoses of syphilis in those 2 years after we introduced universal screening. And we connected all of these women to care. They all got OB care. They all got their syphilis treated. So this is a huge opportunity. Had we tied it to the pregnancy test instead of had it universal, I don't know if the outcome would have been any different. But when you do it as a universal screening, not only are you catching these pregnant women, but you're catching young women before they get pregnant. You're catching their partners. This is an opportunity to prevent this situation in the first place. So, I think what this really says to me is we can't be focusing only on one population. We can't try to identify who's at risk. If you just screen everyone, you're going to find huge numbers. And maybe someday we're going to get to a point like we're starting to get with HIV where we can focus geographically to places where it's high prevalence. But right now, it's pretty much high prevalence everywhere, and it's really difficult. You see, you can't figure it out by the reason they've come to the ED. You can't figure it out by their gender, by their race. You just have to screen everyone. So I really, truly believe that this is the only way we're going to get ahead of this syphilis epidemic. And then just briefly, I will say we did a sample of about 50 folks that came in with syphilis that was diagnosed incidentally through our screening program, and then compared them to a cohort that took a risk factor survey in the ED and looked at the people who had indications for HIV prevention, for pre-exposure prophylaxis, and compared those to the folks who had syphilis, who obviously had an indication for PrEP by the fact of having syphilis, and looked to see who got on PrEP. And of those people, we ended up getting 22% of the folks with syphilis on PrEP at that time of their follow-up appointment. And those people who were syphilis negative but reported some risk factor for HIV, even a lot of them said, oh yeah, I'm definitely interested, I want to come in, I want to have an appointment, I want to get on PrEP. None of them followed up. None of them got on PrEP. So this syphilis diagnosis was not only an opportunity to get their syphilis treated, but it was also a really important opportunity for HIV prevention, which I think is going to be deserving of more research in the future. So in conclusion, it's our responsibility as emergency physicians and people who work in the emergency department with seeing people who may not access care anywhere else. It's really our responsibility to make sure these folks get screened. The emergency department visit is it's really an extremely important opportunity to reach these populations, especially pregnant women who may be coming in early on in their pregnancy and have no plan for OB care, and this may be the best opportunity to get them screened and treated. And this is an absolutely treatable, very treatable disease. And so this really is, we have an opportunity in the emergency department to really make an impact on this epidemic. So thank you so much, and if you've got questions, we'll be happy to answer them. Yes?
So, not surprisingly, that was a fantastic presentation. Thank you so much. So if it's universal and there's only 25% of the patients are screened, what's going on with the other 75%?
That's a great question. So I don't have, it's 25% of the ED encounters, first of all. So that doesn't take into account people who are incapacitated or people who have said no. So it's not really fully 25% of eligible patients. It's probably a bit higher of a percentage. But then beyond that, there's people who decline. There's nurses who click out of the alert because they don't want to order it, they don't want to talk to the patient, they don't want to draw the blood, and so I think there's some loss at each step of the process. And so that's something we're really working on. We actually just last week rolled out I've for the last year and a half been working on this update to the EMR to make it easier to order so that the nurses can make one click at triage, and then it'll automatically add when somebody puts in lab orders. So I'm hoping that's gonna help. Because we just hear like any button click, anything you ask us to do, that's going to create one more barrier. So I think, that's really our goal, is to streamline this as much as possible.
50% is actually pretty high. If you look at other non-targeted screening programs,
Yeah.
you're lucky to get a quarter of your population screened.
Yeah. Oh, that's awesome. I was just kind of curious.
Yeah.
But let me ask one quick follow-up question. We have a ton of patients, like the old ladies from the nursing home, just like inundated with transfers from old patients. So are you screening them, the symptomatic screening with them as well?
So that's a really good question. We are not officially screening them because we tied it to the HIV infrastructure, which stops at age 65 because of the CDC guidelines. But what I will say, and some of this is in our paper that's forthcoming, but when we introduced this screening program, people started taking it upon themselves to put in the orders even when the pop-up didn't show up. And so our number of screened patients above age 65 increased, and so did our number of diagnoses. So we're actually finding them, and it has increased the number of neurosyphilis cases that we've ended up diagnosing as a result. So I think, one of our future areas of study is going to be, what happens if we actually include those over 65 in the screening cohort, and should they be included, not for the congenital syphilis issue, obviously, but because they're also an important population who is affected by syphilis. Yeah.
How much, so aside from just the work of the additional work of screening everyone, how much work and money does it cost to notify all these people and treat all these people? Like, is the department take on that? Did your grant researchers take on that? Or did you pass it all off to ID or primary care?
So ID does it. So in our case, we have a team that is part of ID, and it's we're using a lot of what our existing HIV infrastructure, which is funded in part by Gilead Focus Program, which we very much appreciate. And so we built on that infrastructure. And so we've got, and this is a question I get a lot actually too. They're not clinicians, the people who are like checking the results, because there's always this question of like, do I have to pay for an NP or a physician or somebody to understand? And we trained up essentially bachelor's degree level people to interpret syphilis results and make these phone calls. And so they're not as expensive. And then they will bring them back into the clinic, and then we charge insurance if they have it, or they get, if they're Medicaid, they get that one free visit, the post-ED visit, and they come to our clinic and get treated there. So those charges are kind of like, it's the linkage to care specialists are grant funded, but then the actual treatment is, it's like it's regular patient care. And I don't know if you have
Ours is totally different. We have had no infrastructure whatsoever, but we do have some funding from the state to support navigators. So we have no linkage infrastructure. So we've leveraged we have an existing callback program for people that test positive for chlamydia and gonorrhea and that. So we leverage our mid-level providers to do callbacks. But what our navigators do is they are curating the true positives, the confirmed positives, based on the lab stuff, then populating a database that facilitates the callback so that the MLPs don't have to spend hours trying to sort it out. I'm like the tiebreaker, so one of my jobs is to like work with these, non-clinicians to kind of organize it. It does take a lot of work and oversight, but it's totally working. And we're even with our small kind of targeted program, it's like a full-time job keeping track of the positives and interpreting the test results and calling them back and getting them treated. And we're just kind of figuring it out now. I have one observation that kind of came to me while this was happening. Is that, I've been doing this since the early days of HIV screening, 2004, 2005. And it was, when I think about syphilis right now, with the HIV rollout for screening, we were very practical and we were trying to be very research intensive and like, let's be evidence-based about who to screen and how to screen and roll this out. It's taken 20 years to get to where we are. The syphilis epidemic is so big and so massive that I think we need to be a little more kind of gunslingers and go for it right now, because we can get caught up in the age cutoffs and the protocols and the CDC's like these are the 3 risks, but like enough, because this problem is so big that places just need to do what Kim's been doing and start screening And the numbers are going to tell the tale. And I think, honestly, if the emergency departments don't do this, these numbers we're seeing are, we are too far gone as epidemic. It is really kind of, it's so big, but like, we're just like hearing about it. So I think we have a real responsibility, yeah.
Do you guys have any, I was surprised that an earlier session, like an hour or so ago, someone was sharing some national data about HIV screening in EDs as slowing like down throughput by an average of 30 minutes. And I was surprised to hear that there was a question of if they knew if that included point of care testing or not, but because of the fact that you're including people who are not already having blood drawn and everything like that, I think that has to decrease throughput a little bit. So that's one of my only, I guess, critical, like at UIC, we're at surge capacity, almost getting surge alerts nearly every day, and so thinking of slowing down throughput for something that is in all of grand spectrum less urgent is, I think, a big concern for them.
That's totally reasonable. And you have to be practical here. Like our site, we don't do screening for patients that aren't otherwise getting blood drawn unless the physician thinks that it's clinically indicated. That's just the decision we made. And that is based on our site-specific data, looking at throughput times. And it was also just our nursing staff just would not draw blood in a patient who the only indication for drawing blood was screening. Now, I know that we are missing cases. I'm not surprised when Kim says you're going to miss 20% of the disease that's out there. And I understand that. But I'm also looking at the public health, like the impact we can have in leveraging people already getting blood drawn. It's one way to do it. It's going to work some places and not others.
I will just say too, like I'm familiar with what you're talking about, and I think they did not differentiate because their programs are designed in so many different ways, right? Some of them are point of care. Some of them, they do counseling in the ED. They wait for the results to come back so they can talk to the patients. They do risk factor surveys to decide if they're going to draw blood. Like there's all these different models, and we are trying to see if we can get clean enough data that we can actually put this out from our program, but from just watching it in our program, I don't think it actually adds any time because we're not waiting for results to come back. They're not holding people in the ED to draw blood. They're doing it while they're waiting for the doc to come and talk to them or write up their discharge papers. Like no one is holding up anything to get that blood drawn. And then once the blood's off to the lab, no one's waiting for it to come back. We just they send it off and then no one thinks about it again because I've got a team outside that's following it up. So I truly don't think, even though we're doing this in some people who aren't otherwise getting blood draws, I don't think it's actually adding to our time. I think if his data were granular enough that you could drill down, I think you would probably find a lot of that increase in time is because they're actually holding people to talk to them about results and things like that.
They also did included diagnostic testing and EDs that were only doing HIV testing diagnostically, which is a huge difference because those patients are probably symptomatic.
Yeah.
Right. We do have a trouble in our low acuity, fast track area, because there is a real push to you're discharging them while you're talking to them. And that's just those patients are the same patients. They're just, next week they're going to be an ER patient. So it's a hard pill to swallow knowing that you're sending some people home that should be screened. But again, I'm coming at it from the long game here.
But I will say too, when we first rolled this out, I got this pushback oh, no one's going to want to do the blood draws and it's going to, it's going to add work and add whatever. It took so little time to get this integrated into our workflow, and now everybody just sort of takes it as this is what we do. And it's not been a big deal.
The problem is once you take something away, you can't go back. I could not imagine going back. Even if I wanted to be there's all these missed opportunities. I think it would be hard to go back and ask them to do screening in other patients. So I don't know if there's anyone in the room that's starting from scratch.
Yes.
Go big. Start big and you can
That's right.
peel back later, I guess. You had a question?
Yeah, thank you so much. This was super interesting. So I have two quick questions. One is, so do you verbally consent everybody for HIV and syphilis testing before you do it? Or if somebody's getting a blood, I know HIV is blood very important, but I often just order syphilis without necessarily explaining to patients. I'm wondering if you do that for this process. And another thing I wondered is, I know you mentioned that pregnant people seem to all be able to be reached and follow up. If you have an issue where you have positive results and then aren't able to track folks down, how big of a problem that is?
So it is, so Illinois, the law is that everyone has to have an opportunity to opt out. So it's not technically that we're consenting them, it's that we're informing them that we do screening and then, you know, giving them a moment to say, no, I don't want it. So yes, we do that. But the consent part is technically part of their consent to general medical treatment. So what we do verbally is we inform them that we do screening and we make sure that they don't say that they don't want it. And then we click the button. That's why we have it in the BPA instead of automatically adding it to the order. For syphilis, there is no such law, and if you're just wanting to send a syphilis test on somebody, you can. When we rolled it out, because it was not sort of following existing national guidelines, which we hope will be forthcoming in the next year or so, but since there's not right now, we decided to include it in that same alert, partly for infrastructure reasons and partly because we feel like it's appropriate to inform people and give them a chance to opt out when it's not sort of part of a standard guideline. But, you know, that being said, things like hepatitis C that do have guidelines that say everyone should be screened, we just added that on and we're not telling anybody with just posters, but we're not doing opt out because it's like a standard of care.
The public health department relationship is key here. So you will have patients falling through the cracks and you can't sort out, you lose. So like, we've been working so hard as our run up to expansion to like really establish serious working relationships with our local health jurisdiction and who do they have that can help with kind of surveillance and follow up. And because we're losing patients falling through the cracks right and left. We can't get a hold of them. So we have kind of bi-weekly meetings. We have our list. We fill out our confidential reporting to the health jurisdiction, and then we basically say we can't follow, we've lost them, and then we hand it off. Now what they're doing is hard to know, but at least that is the process that you should have in place.
And I will add two things that have helped us too is text messages, because people don't answer their phones anymore. And so now we not only call them, but we send them a text message. And then if we don't reach them that way, we send them a registered letter. But then the other thing that's really made a difference is that when we get through that whole process and we haven't reached them with text, we haven't reached them with phone, we haven't reached them with the letter, or when we send out the letter, we put a chart flag in. And the chart flag says, if this patient comes back to the ED, please find out if they have syphilis, you know, if they've been treated in the past for syphilis. And if not, then like let them know. And we're not asking the ED clinicians to treat the syphilis, but just to make sure we have like a phone number for them, that the patient knows that we're going to reach out, and you know that they've documented whether they need to be treated or not, because some of them are just previous infections. So the chart flag has made a big difference because it allows us to address it when they come back to the ED. Are we in trouble?
I don't think we're in trouble because I know it's opened that door. I'm hoping there's not I don't think there's anything after this.
No.
So
We can stay and talk about syphilis all night.
My flight's not until 8 tomorrow morning, so I'm good.
We're just like a
Because they want to
We're gonna leave it
Yeah. Yeah, Chris.
I think you guys are the last session.
Okay,
All
thanks.
right.
This is a great talk. Yeah, I really appreciate it. What about payment? I mean, I think that's the other big pushback we get from people.
We are
And
running
one of
into
this
that.
is like, since there's no national guidelines, how do we know if you haven't documented risk factors, are people's insurance going to cover this, or do you have a big
Just
bill?
use a diagnostic code that says they're at risk. Just the bill, you have one universal charge for your syphilis order. And don't use screening asymptomatic, use some sort of generic risk.
Our billers have been adding that, like, it's on there,
That's fine.
it's complicated, but they've been adding the like encounter for STI screening or whatever,
Yeah.
the encounter for HIV screening, and most of ours have gotten covered.
But
So
that
you
is,
did proactively work with your billers and coders to ensure that they're coding it?
just use the same thing that right now if you were to order a syphilis test, it's already there, we don't pay attention to it, right? You order a syphilis test, we're all doing it all the time. You can call your whoever's in charge of your lab and they'll be like, oh, we use this code, and when you go pull it up, there's all sorts of options, and like we had to do this when we set up our HIV program to come up with a generic code that was guaranteed to get reimbursement that wasn't too specific. So that's what we have done. But yeah, no, there's people are going to try to. We're actually running into the first time, like our hospital admin is like, thinks like syphilis screening is like a bad idea. And this is the first time in my whole career that I'm like, have to like justify what we're doing.
Well, I was gonna ask that, I mean, are there any cost effectiveness studies? I actually don't know a lot about, because we did Hep C cost effectiveness, and like when you look at Hep C, it's pretty easy to make the cost effectiveness argument because of the comorbidities of liver cancer and so many other things, and transplant that's needed, but I'm not sure if that's there on syphilis. I mean, obviously you've got the population impact of it being infectious, but you don't have that same type of morbidity, mortality.
Well, you do though, you do. If you think about all the people that get hospitalized with like all the various complications of tertiary syphilis, with neurosyphilis, if you look at actually the cost of a hospitalization for a newborn with congenital syphilis, it's in the hundreds of thousands of dollars because they have ICU stays and it's a whole thing compared to like, I think the average is like 40 or 80,000 for like a regular newborn stay. So like even there, if you're looking at those, you know, the 4,000 babies with congenital syphilis, right, that's millions of dollars right there. So there hasn't, as far as I know, been a cost analysis yet. This is what I'm going to be spending a bulk of my next 2 years working on, so hopefully that'll be out there soon. But I think just like thinking about the amount that is spent, you know, for those like pretty severe complications, I anticipate we're going to find it's cost effective.
I mean, I think Hep C, hospitals are into it because they use their 340 price that you can show. I treated 3 people for Hep C. I paid for my entire program for 2 years. Like, people are not driven by long-term disease prevention. Is not saving anybody money, but like Hep C, like, so I just think syphilis is going to be like, syphilis is going to have to be driven by our local health jurisdictions have to basically like really support us in this, like our state health jurisdictions, like, because I do feel like this next 5 years is like the window, the opportunity is right now.
Yeah.
And penicillin.
Yeah, well, that's true. The
Treatment's-
drugs to treat it are so
treatment is
cheap.
really
It's like a shortage though.
not, it's
Well, now they're importing
Almost better.
Extensylene from France,
yeah,
so that
we're-
helps.
We're about to like,
Yeah.
it's all, we're good.
Yeah. Yeah.
Where did it, as you said, they don't necessarily come back and leave with treatments, or do they go to IV clinic, or like where do they get their treatment?
So we are incredibly lucky because we actually have an STI clinic in our hospital that does all of our follow-ups. And if they can't go there, they go to sort of there's like it's the equivalent of an FQHC that's kind of associated with us, and so we'll see them there. But we do make sure that they have a place that they can come back and be treated by, you know, our people.
Ours is more complicated because we don't have like a dedicated place for someone that needs to be treated. So we're either prescribing doxy in certain cases as an alternative to penicillin, which is driven also by the shortage of penicillin, but it's also a way to treat patients without them coming back for care. So that's something that we're doing quite a bit. We're also utilizing our fast track area of our ER. I'm like, if my hospital is cool with everyone coming back people come back to us all the time. I'm like, you know what, you got syphilis, you want to come back and get a shot? Like, I'm going to do it until like someone says I can't do it. And you know, people come back for their restarts and they come back for their wound checks. To me, this is just a disease just like anything else. So like, I'm going to just let that organically unfold. Yeah.
Yeah.
Do you have any data on the, like, adherence or follow-up of the doxy? Like,
Well, I can tell you all the doxy I prescribed for every other reason, and I'm told the patients hate it, they get nausea, they get diarrhea, and they stop it. So this is the problem with doxy for syphilis. Depending on your stage, it's either 2 weeks of doxy versus an entire month of doxy. So doxy has real challenges with adherence. Penicillin is the way to go.
Although I will say the caveat to that is if you've got, you know, if you don't have primary or secondary syphilis, you've got to come back once a week for 3 weeks for your shots.
Yeah.
So I think this past year of the shortage is going to be a really interesting natural experiment to see if people are more likely to be adherent to that long course of doxy or to coming back to 3 appointments in a row. We're actually pulling some of that data and looking at it because we've been calling people to find out if they took their whole course of doxy. And so we're going to try to look back and compare whether people were more likely to, you know, take that whole course of doxy or actually show up for their appointments. But it's a really good question either way. It's not an incredibly, you know, fun way to get it treated.
Because we are screening mostly patients that are getting blood drawn, we use the reverse algorithm, so we will get our triple pneumonia antibody test back usually while the patient's still there. So it does, depending on how engaged the physician is, whether the patient has symptoms or not, we will often we're training our docs to like have very low thresholds for treatment, at least get that first dose of penicillin going. Then we can sort out who needs additional doses or not. So depending on how you set it up, you know, a certain proportion of patients will be treated at the point where you're like sorting them out on the back end. But it was a bit complicated, but it's not like, it is doable, but it will require you as like to really understand your department, the testing, the interpretation, what your patients are like, what your threshold for physician empiric treatment is. Like, I don't know, the last year just kind of running up to this, to where we're at, has been a lot of work without like a whole lot to show for it yet. But I do think like the next couple of years are going to be pretty interesting to really dive into this field.
But I think you'll find if you start screening, you're gonna find that all kinds of things that you couldn't explain before, all of a sudden they're gonna get explained. You're gonna find people that were like dizzy or having vision problems or having, I mean, we found syphilis like with colonoscopies where we found spirochetes and that, you know, like, I mean, it's everywhere. And we're getting people who are admitted to the hospital and we don't know what's wrong with them, and then the tests come back. And then all of a sudden it all comes together. And it would never have come together because no one would have thought to screen them if we didn't just automatically screen everybody. And I don't think it's just my hospital. I think everyone in this room, probably if you started screening, you'd have the same experience.
We used to see that with HIV back in the
Yeah,
day.
absolutely.
Some
So
weird
different.
presentation, some dumb intern orders the screening HIV test and fax the kid.
Yeah.
These numbers though are so much higher than what we were seeing with HIV.
Kim, or I don't know, either of you know, so with the reverse algorithm is, because I remember our lab lost their mind when they were like, I don't know who approved that at University of Chicago, who in their lab did that, that's not appropriate to be using on a universal screening population,
What?
you know. And is the risk the, like, false positives or false negatives, or do you know? Because like Doug really got me inspired of like, we are literally set to start our targeted syphilis screening next Thursday, and I'm like, man, I just want it to be universal so bad, but our lab has been like, we
It's a-
approve you doing targeted screening, absolutely not universal.
And they want you to do an RPR, not to do reverse
No,
algorithm?
they're doing reverse algorithm, right?
We do, yeah.
I mean, the reverse algorithm is nice for a large scale testing program because it can be automated.
Yeah.
RPRs are an old fashioned test that require a lab technician to like process and like look under a microscope and make some subjective assessment on the result and the RPR titer. So like for larger scale stuff, the lab is always going to want to do the reverse algorithm that it
Yeah.
starts with. But the problem with it is once you're positive, you're positive. So you still need the history of the patient, prior treatment's important, and then putting into context their RPR. So
Yeah, I thought it was the sensitivity specificity that they were concerned about, of like that if you're doing it on a non-targeted population that is not known to be at risk, that was their concern.
well, sure,
I was
if
so
you're going to have
resistant
false.
to syphilis at the point that I was having that argument with them, that I was like, maybe you're valid, maybe this is valid, maybe it's not, so that's where I'm like.
Well, but it doesn't make sense to do RPRs on everybody because you'd have to hire like a bajillion lab techs to
Right.
pipette it. I mean, you couldn't. This is really the only way to do it in this volume of a population.
It's generally true if you screen.
Well, the initial screening test, yes,
Yeah.
but they all reflex to RPR, and then if the RPR is negative, they reflex to TPPA. So by the time you get to the end of that algorithm, then it's not a false positive anymore.
But they're right though, that in terms of you will have more people going down that algorithm
Yeah.
that don't have syphilis, never had a risk for syphilis. But that's like, if we want to do this, that's gonna happen. And you know, if you screen low prevalence populations, you're gonna have a disproportionate number of your positives are gonna be
Right.
going to be false positives. But that's not going to be the case with syphilis right now.
That's like saying you
Those
should.
patients are going to have
Right.
had syphilis or currently have syphilis, so.
And it's like saying you should do a viral load on everyone for HIV screening, right? Like, that doesn't make any sense. Like, of course, we have false positives at that initial HIV screen too.
Sure.
But then it reflexes and then we have the actual,
But I mean, you'll be in the position that I'm in, where you start with this target, and then hopefully you can expand. Show some numbers, show a couple of lives saved, a couple prevent some congenital syphilis right off the bat, like, okay.
Well, thankfully, because of the fact that it's driven by a BPA, most people won't know that I've changed the logic for the BPA in the background. They won't have any idea. They will know if I change it to like not be based on a blood draw. That's where I don't know that,
Yeah.
that would be really hard.
Yeah. All right. Thanks for
Thanks,
thanks everybody.
staying.
Yeah.
So